purposes. One, the blood sample that we take from the babies will serve two purposes. One is to be able to do the TMS or the MSMS testing for the acyl carnitines, the organic acids and the fatty acids and the amino acids. Then we can also store some amount of urine. It's quite a good idea to even do a suprapubic puncture if the baby has not passed urine or like that, because it's a really a critical sample. Then sometimes if there is a CSF, one can store the CSF. So the dictum for CSF is that it really has to be frozen immediately. So because all these metabolites that we are trying to catch, they are quite volatile and you will not find them unless the sample has been snap frozen. So these are the three critical samples: blood, and blood you can take in EDTA, which will serve for the biochemical genetic testing as well as for DNA. We can take in a plain tube, because many a times we do certain assays on serum. So like even like CPK or any other test, LFT, creatinine, uric acid, there's so many, homocysteine we would like to do. We can all do that in the serum sample. And also some specialized metabolic testing, like congenital disorders of glycosylation. So they really serve as critical samples. So plain blood is also a good idea, but not one should not keep it like a whole blood. One should extract the serum out of the clotted sample, and that's the sample to be kept frozen. Because if you just freeze the whole blood, it will be hemolyzed and it will not serve you the purpose. Then blood, urine, CSF, and sometimes people say bile, but it's really difficult. If possible, then we go to invasive. One could do a little skin biopsy and keep it. That we try and do sometimes when we are really suspecting, because in our hospital we do have the provision of the culturing of these skin cells. So we create skin fibroblasts. One could archive them for long-term storage, because they are the source where you can actually do the high-end functional testing. So it's being done in all the major centers abroad, but we have just started doing them. We could do a little biopsy of the liver, of the kidney, supposing the child had acute kidney failure. So one could take a kidney biopsy, liver, heart biopsy. All these biopsies are also very, very helpful. Sometimes one could do even like a post-mortem MRI. So that is also possible, because one would like to know what is wrong, may not have had a chance to do this imaging while the baby was alive because of ventilation and things like that. But if it really comes to that, one could do that. So these are the things that one can do. Yeah.
Another question that we had, ma'am, was when do we send for testing after PRBC transfusion? What should be the gap?
Okay, so this has been studied quite a lot. Previously, one used to think that one has to give a gap. So let's just break it down. What are we testing for? Usually, if it is a genetic test, which is like a gene sequencing or whole exome, microarray, things like that. So what you are utilizing are the leukocytes. So when you have given PRBC, you are presuming that they are usually depleted of the leukocytes. They are not carrying very many leukocytes, number one. Number two is that the half-life of these leukocytes is quite low. It's much less than the RBC. So one could, and then there have been studies also to see whether it is possible or not. So as little time as 1 or 2 days, one could take sample. If they are DNA-based test or chromosomal-based test, you can take a sample as early as like 2 days post a PRBC transfusion. So that's one. But there are riders. So if you are going to test like galactosemia or any other test where RBCs are being tested. So particularly I said galactosemia because there the enzyme or even the galactose metabolite, they're all in the RBCs. So if you are going to test the enzyme, you will invariably get those donor RBCs and you'll get a false result. And you really have to wait for higher, like 4 months, they say, 120 days. So it's difficult. So, but what we manage to do is we don't do the enzyme. We can do the metabolite. We can test the galactose because that can be tested in the plasma. It is a very sensitive marker. It will not go anywhere if the baby has been on, lactose milk. So any other on, I don't remember any other test that we need to defer because of the blood transfusion. So I guess that's my answer.
Another in the line we have, ma'am, when to order microarray and where to order whole exome sequencing. Is there any clue to suggest microdeletions or duplications?
Okay, so microarray is now the standard for studying all the chromosomal abnormalities. It's no longer a karyotype. Karyotype is only recommended in aneuploidies. That's all, because you don't really need to do that high-end test to be able to confirm a Down syndrome. So, or even a Turner syndrome. So all these karyotype, the utility of this karyotype is fast reducing. It's a very basic test and it is very labor intensive. So that's why many of the labs are doing away with it. So microarray is the standard test to be ordered in children where you want to test the chromosomes. And why we want to test the chromosome? Where you're suspecting a chromosomal either deletion or a duplication in a smaller region or a higher region, bigger region. So when do we suspect these? Number one is congenital malformations. So because malformation have to have a bigger degree of abnormality in order to come around. So a bigger chunk of DNA, if it is involved, it will involve in the many number of genes. So a working together of so many genes is defective. That's why it creates such bigger abnormality. So usually, if it is not a recognizable monogenic disorder, because there are many even single gene disorders which will present with malformations. Let's say Noonan syndrome, they can have congenital heart defects, but it's a single gene disorder. But by far they are less in number. Majority of the, like I said, in malformations, 20 to 30 or even higher percentage of them will turn out to have a chromosomal disorder. So bear in mind that if there are malformations, you should order a microarray. Then other thing, in slightly older or failure to thrive also, like small for gestation, fetal growth restriction. The growth abnormalities are also sometimes due to chromosomal errors. Then encephalopathy seizures in like lissencephaly, along with some kind of malformation, if there's some, or dysmorphism. So these are also pointers for microarray in the neonate. So, but one has to first see whether it fits into certain syndrome or not. So the clinical evaluation is very, very important.
I have another question, ma'am. One was,
Yeah.
should we do genetic testing in all major cardiac anomalies?
So genetic testing, all major cardiac anomalies should be done. Any malformations should be tested for genetic conditions. Uh, um, sometimes it may not be genetic. If you have an apparent cause, like it could be a teratogenic effect, it could, and if there is a stark evidence to state that, you may do away with the genetic testing. But by far you should do this genetic testing and start with chromosomes if there is not, there's no clear answer in your clinical evaluation, and then you can go on to do even the whole exome to find out the genetic fault.
So, ma'am, your take on variants of uncertain significance.
So it's a very gray area. So let's start with what is a variant. So variant is something which is out of normal. But then what is normal? We all are individuals. We are all very different to look at. We are all very different in height, weight, color, etc. And our intelligence level, everything is vary. So what brings about this variability is our changes in our DNA. So we have, every individual has like, so 1 out of 1,000 base pairs, there is a variant. So we are different in 0.1% of our DNA makeup. So this is a variation or a variant. But we have to then see what is the relevance of that variant. So the American College of Medical Genetics, ACMG, brought out a classification of these variants. So whenever you come across a variant, the lab or the clinician has to classify it. What kind of variant is it? So on the one hand, there are variants that are benign, which means they do not cause any interruption in the function of the gene. They are merely causing a difference. That's all. तो वो normal होते हैं. They are quite common in the general population, because that's how us Indians still resemble each other. We don't resemble the Caucasian because their variants are different. Ours are different. They are polymorphisms. तो जो common होते हैं उनको हम polymorphisms बोलते हैं. Then on the other side of the spectrum is a pathogenic variant, which means disease causing. A variant which has made the function of the gene, which has disturbed the function of the gene. So that is a pathogenic variant, disease causing. So this is one spectrum, this is other. Then close to the benign is like a likely benign, which means you're not entirely sure that this is a benign variant. So you can put it into this category. Here, there is a category called likely pathogenic, which means you think that it is disturbing the function of the gene, yet you're not 100% sure. So it's a likely pathogenic. So then comes the middle, the gray zone, which is the variant of uncertain significance. So this sits right in the middle, where you cannot classify the variant into either the normal category of benign, likely benign, or the other category of pathogenic, likely pathogenic. So they are the variants which need more work. So we have to do something to be able to put it in this basket or this basket. So more work is required. One cannot take this variant on the face value. So it is not really up to the lab to classify it, because they can only do a little bit. They can do computational tests, they can study the chemistry of the variant, what is it able to do, but it will not be able to correlate it with the disease. It will not be able to see the family tree and try to segregate and all that. So lots of work is to be done when you see or come across a VUS, or a variant of uncertain significance. So now this variant is possible also on microarray, because these variants are like bigger chunks of DNA getting duplicated or deleted. They are also variants of uncertain significance, right down to the single nucleotide. So they should be taken very seriously. What is happening all over here is that the labs are mushrooming and they want samples, so they are reaching on to every physician who may not be well versed with this, and they are ordering this test. And once they find a variant, they either in their mind make it like a disease, they associate it with disease and label the person with that particular diagnosis, which is wrong, or they don't understand the significance and they leave it, they ignore it. Both of these are wrong, because that variant of uncertain significance could actually be the disease causing variant. You have to look at it, you have to have an expert opinion about it. So, and it could be benign as well. I have seen a lot of cases where the fetal medicine specialists have actually done the test and then used that variant for prenatal diagnosis, which is very wrong. It just cannot be accepted. So please don't take this. I'm very happy for the question, because one has to, this variant of uncertain has to be further studied before any conclusion is drawn.
Another question that we had, ma'am, for diagnosis of Down syndrome, which is best, either karyotype or fish?
This is just a matter of time. So if looking into the anxiety of the family, you would really like to have a quicker diagnosis. So that's when the fish comes in, where you can give a result in 1 day or 2 days. Whereas a karyotype does take time. So in my hospital, it takes about 2 weeks. So when you want a quicker diagnosis, use fish. Or when you want a confirmed diagnosis, but there is no problem in waiting, do a karyotype. And like I said, these are only meant for very few conditions where, the larger chunk of chromosomes are involved, like the aneuploid, where the whole chromosome is duplicated, like that.
Uh,
Fish is also good for identifying mosaicism. So, but that's less of a scenario.
I think the another question was also the same, that was suspecting a trisomy. Is it better to do the fish or karyotyping after the sepsis is resolved? Mm, what does that mean? I
Yeah, there is no relation to sepsis there. It will not alter your chromosomes. You can do simultaneously.
Another question that we had, ma'am, will antibiotics have an impact on genome sequencing, chromosomal microarray, or karyotyping?
Not really.
So after a double volume exchange transfusion, when to send whole exome sequencing?
Okay, so again, probably it's the same question as a transfusion, right? So one could, if you are really wanting to do it quickly, then wait at least 2 days, I would say. And if you cannot wait, then take another sample. You need not use blood. You can skin biopsy or some other tissue. So some labs have started doing on buccal smear as well. So they are independent tissue samples which do not get impacted by bloods.
So are there any AI tools to help in diagnosis of dysmorphic neonates?
There are. So lots of tools are coming, but again, bear in mind, they are just tools. We have to use our minds. So there is a tool called face to gene, which we use. And but then this is you take a picture and you put it in the app, and it will give you a differential for 30 disorders depending on the likelihood of that syndrome coming up. So sometimes there is only a very small uh, bar which says that, a little suspicion. Sometimes it goes full on. So that's the gestalt meter. So we have been using it, and you feel free to use them, but then you will need a lot of guidance for that.
Another.
I'm not aware of any other tool, but there might be more. Yeah.
So does blood transfusion or exchange transfusion affect TMS? Is it necessary to store the sample before transfusion?
So, because exchange transfusion might involve, the total blood volume to be exchanged. So you are also taking out the plasma and everything. So that's why it may have a slight impact on the TMS, because what we are measuring in the TMS are those metabolites, those chemicals that are free floating in the plasma. They may be inside the cell, but majority of them are in the plasma. So if you are changing that, then it'll take some time to get back. Sure enough, if the condition is there, they will accumulate again, but it will take some time. So it's better to take the sample prior and then go for the transfusion.
So what is the role of genetic test in congenital malformations not fitting into any syndrome? When and which test we send?
So number one, it's very important to clinically analyze and to seek the advice of experts, because there are very many malformations, and you may not, it may be sounding very weird to you, but then the expert might have seen 2 or 3 cases and then he becomes the expert. So it's important to share your malformations with the expert and seek their advice, number one, because it could go either way. It could turn out to be one particular very specific syndrome, or the person could just go ahead and do the general testing that you might have also done. But if you don't have anything in specific in mind, so you can go start with a chromosomal microarray.
Another last question that we had, ma'am. What is the gestation age to do TMS? And 7 disorders in preterm neonates. Why specific gestation age? The participant wanted to ask.
There is there's no gestational age as such for TMS. It is basically the time of birth and the time elapsed after that. So let's just break down what we are testing in the TMS. So for 7 disorders, let me just point out that for hypothyroidism, for congenital adrenal hyperplasia, and for G6PD, these are all, and the biotinidase, they're all separate disorders, and the answer is totally separate. Hypothyroidism, there is a slight catch here because the preterms may not be able to mount that TSH response. So there may be many false negatives. So you may have to repeat it after a certain time. But for the others, like G6PD, biotinidase, they're all enzymes. They will remain the same. You can do it. And for TMS, because when we are trying to do the metabolic testing, you require some, like feeding, some time to have elapsed, and baby should have been on some feeds for those metabolites to accumulate and then be picked up. So, and it doesn't matter whether this was a 30-weeker baby or a 40-weeker baby. It's the time after birth that is more important.
I think these are the all questions that we had, ma'am. On the behalf of IN, ma'am, I actually want to thank you. Really, it was very fruitful for
Such a
us.
pleasure.
And actually, ma'am, we had the maximum attendance today. We had 100 participants
Wow.
participated, so this was the highest that we have achieved till now.
Amazing. Thank
So
you
this
so
was
much.
the
I'm so
highest
happy.
number that we had for the session today. So
Excellent.
thank you so much, ma'am.
I think you guys are doing a great job, because this is what one should know. One should train our juniors and make them, equip them with everything, all the knowledge. So that's good. Thank you.
We are honored by your presence, ma'am. So before you leave, I had one last question. So we can send
Okay.
TMS in a 28-weeker baby on feeds.
Yes. Yeah. You may send even if the baby is not on feeds. There is no such contraindication, because again, the accumulation of metabolites is not just dependent on feeds. It is also dependent on the acute illness of the baby. If the baby is acidotic and not had any feeds, the metabolite would still be there. So you can still, acute sickness is the crux. If you are doing the clinically, clinical symptomatology based testing, not the routine newborn screening. That's what I'm saying.
Thank you so much, ma'am, for your presence.
Okay.
Since you have taken much time of yours, late night. Thank you so much. You agreed for this session, ma'am.
Thank you. Thank you. I really enjoyed it. Thank you so much for inviting me.
Tanveer, would you like to have some ending remarks or something?
Nothing. I think you've thanked, ma'am. Only thing I need to do is thank you so much, ma'am. You've taken time off.
Thank you for inviting me. It was a
Your
pleasure.
presentation was very beautiful. Your analogies were very beautiful, ma'am. I mean, real life analogies like what is a train, what is an exon, what is a whole genome, and all. And I think you started off with the basics. I think
Yeah.
basics is like a foundation on which you can always build on.
Absolutely.
That was very good.
Yeah.
I think the doubts will keep pouring in, ma'am. We can have certain, some reports which we may need to. You can give an opinion on
Yeah,
those.
we can have some report session someday. You can ask your participants to send in your queries, and we can sit and we can analyze all of them one by one.
Yes, yes, ma'am. If you could do that, I mean, that'd
do
be
that. Not a problem.
practical scenarios counseling it.
Yeah.
Thank you so
Anytime.
much, ma'am. It was very nice.
Okay. Thank you. I am. Bye bye. Good night.
Good night, ma'am.